Hello, my name is Dr. Madhumita Kumar. I'm here to speak about the heart-liver axis in alcoholic hepatitis and ACLF challenges and strategies. I have no relevant disclosures. Prolonged consumption of alcohol results in oxidative stress, neurohormonal activation, which leads to direct myocardial damage, increased collagen and fibrosis, uh, altered nitric oxide pathway, and which further leads to LV dilatation and dilated cardiomyopathy. All these are modified by gender, thiamine deficiency, race and ethnicity, and genetic variants for heart disease. Low amounts of alcohol are cardioprotective because it increases HDL, lipoprotein A1 and A2, reduces CRP, and reduces platelet aggregation. But in case of prolonged consumption, there is increased PI1, endothelial dysfunction, hypertension, which can predispose to sudden cardiac events. Consumption of more than 80 grams of alcohol or more per day for more than 5 years can cause alcoholic cardiomyopathy by protein synthesis inhibition, fatty acid ester accumulation, free radical damage, calcium myofilament interaction, and inflammatory factors. Cardiomyopathy is manifested as arrhythmia such as atrial fibrillation, flutter, supraventricular tachycardia, increased risk of stroke and hypertension, sudden cardiac death, and even withdrawal of alcohol is associated with Takotsubo or stress-induced cardiomyopathy. Light or moderate alcohol consumption may be cardioprotective. There's a marked change in our understanding of pathogenesis of the alcohol cardiomyopathy and alcoholic hepatitis in this autopsy study from 1983. They concluded that all these patients of alcoholic cardiomyopathy did not have cirrhosis or hepatitis, and these two conditions are rarely concomitant events. This study from 1995 assessed 30 patients with cardiomyopathy, 30 without cardiomyopathy, 20 alcoholics with cirrhosis, 15 abstaining alcoholics with cirrhosis, and 15 non-alcoholic cirrhosis. And they found cirrhosis was there in 43% of patients with alcoholic cardiomyopathy as compared with 6% of alcoholics without cardiomyopathy, and 50% of active drinkers with cirrhosis had DCMP. This suggested that there was definitely an association between the two diseases. Cirrhotic cardiomyopathy is associated with electrophysiological abnormalities like fibrillation and QTc prolongation. Membrane, cytokine, and growth factors can all cause an increase in the circulatory dysfunction, causing an increased cardiac output in the compensatory phase. Thereafter, the patient can develop either heart failure with preserved ejection fraction or heart failure with reduced ejection fraction, manifested as systolic and diastolic dysfunction. The two-way street between cardiac dysfunction and the liver dysfunction is because reduced perfusion can lead to further hypoxic liver injury. The ratio of Doppler velocities, that is an E by E ratio, is an independent predictor of organ failures, acute kidney injury, and survival, and higher grades of diastolic dysfunction were associated with lowered survival. The neurohormonal activation and the presence of portal hypertension is associated with peripheral and splanchnic vasodilatation, and in the presence of systemic inflammation or sepsis, there is relative central hypovolemia with a hyperdynamic circulation, which results in increased heart rate and cardiac output. When this compensatory cardiac mechanism fails, it results in heart failure. Therefore, in the presence of any stressor such as step shunt or liver transplantation, patients with diastolic dysfunction, that is those with an E by A ratio less than 1, have a lower cumulative survival. Our own data showed that the presence of higher grades of LV diastolic dysfunction was an independent predictor of mortality. There is increasing data to suggest that this decreased cardiac reserve neurohormonal activation results in risk of HRS, refractory ascites, hyponatremia, and secondary organ failures in ACLF. In this retrospective analysis of 114 patients who underwent TIPS in the Neptune cohort, those with a GLS of less than 16% was found to have an increased risk of development of ACLF, and the survival of patients was also better in those who had more contractility following TIPS. This suggests that there is a poor augmentation of cardiac output in alcoholic cirrhosis. Understanding the cardiac reserve is critical to our understanding of when beta blockers can be useful in cirrhosis. So as the disease progresses, hormonal activation rises, cardiac reserve tends to decline because the patient goes into diastolic dysfunction. Thereafter, when the cardiac output starts to decrease and MAP is not maintained above 65 to 70 millimeters of mercury, the risk of giving beta blockers outweighs the mortality benefit. This interesting data studied the systemic hemodynamics of patients with decompensated cirrhosis and found that patients who had a maintained cardiac output, they had better survival on beta blockers, which suggests that monitoring cardiac output might be a better way to assess outcomes in beta blocker therapy. Moving on to the risk of coronary artery disease in patients who have alcoholic liver disease, there is an increased hazard ratio of 1.7 for a sudden cardiovascular event, and this is largely related now to the association of gut dysbiosis, systemic endotoxemia and inflammation, atherosclerosis, and increased risk of ACS and heart failure. Alcoholic liver disease is also associated with increased electrophysiological abnormalities such as increased QTc interval prolongation. However, risk of mortality is there with atrial fibrillation and the presence of MELD. The higher MELD score patients were found to have increased risk of atrial fibrillation. Cardiac evaluation is also essential before taking up patients for liver transplantation, as the cumulative risk of cardiovascular events post-transplant is 13.5%, most of which are acute coronary syndromes. So the survival in patients with and without a cardiovascular event after 3 years of transplant suggests this is a major determinant of survival after transplantation. Aortic cardiomyopathy is associated with multi-system involvement, including the portal hemodynamics, change in the splanchnic vasculature, and change in the renin-angiotensin system and the kidneys. The diastolic and systolic dysfunction are graded as per the ASE guideline with now numerous supportive criteria. Briefly, the point of care echo starts with the parasternal long axis view, where we look at the left atrium, the mitral valve, the LV outflow tract, the right ventricle, and the LV contractility and the volumes. We can look at the LV contractility better in the parasternal short axis view. Thereafter, moving to the apex, and we look at the four chamber view, where we get the stroke volume and the ejection fraction. We can calculate the velocity time integral and look at the right heart. And finally, moving to the subcostal view, we look at the IVC dynamics. Calculation of the ejection fraction by Simpson's biplane method and the VTI can give us the cardiac output in real time. So the E and A ratios are the early mitral filling and the atrial contraction, which leads to late mitral filling, and it is graded according to different Doppler velocities as grade 1, 2, and 3. And then we also look at the tissue Doppler or speckle tracking imaging to grade the diastolic dysfunction. The older criteria for LVDD were as per the American Society of Echocardiography, which use the tissue Doppler, the EE prime velocity, and the deceleration time to grade LV diastolic dysfunction. The newer criteria incorporate global longitudinal strain, change in the E by E ratio parameters, left atrial volume index, serum biomarkers, and cardiac MRI imaging. But not everyone is convinced about the utility of these newer criteria to assess the cardiac reserve and the blunted cardiac response to stress, which presents a worse prognosis in ACLF and critical state. So both ECG, transthoracic echo are useful for the diagnosis of cardiac dysfunction and are essential. The use of cardiac MRI can now detect structural changes. In patients with acute decompensation, a reduced cardiac output as a manifestation of cardiomyopathy is associated with the development of AKI and HRS and infections such as SBP. QTc prolongation is common, but it is not clear whether it affects prognosis, and detailed cardiac evaluation should be part of assessment for TIPS insertion and liver transplant. A number of new biomarkers have been proposed in cirrhotic cardiomyopathy, including troponin I, galectin-3, procalcitonin, endothelin 1, and the markers of AKI such as cystatin C and NGAL. The role of cardiac MRI has gained increased prominence in the newer diagnostic criteria, especially when it comes to extracellular volume determination in the myocardium, and also late gadolinium enhancement, which can be used to grade diastolic dysfunction. Thus, the heart-liver axis actually involves multiple organs in the setting of cirrhosis or ACLF, with components of systolic, diastolic dysfunction, and electrophysiological abnormalities. Cirrhotic cardiomyopathy is an independent risk factor in HRS, critical illness, insertion of TIPS, risk of PICD, and post-transplant outcomes. Coronary artery disease is independently associated with mortality due to sudden cardiac events. I thank my team for their support and thank you for your patient listening.